move forward with session number 8, echocardiography in the evolution of. I would request the following respected doctors to please take the chairperson panel. May I request the presence of Dr. Pradeep Kumar Shah, Dr. Tushar K. Patra, Dr. Vikas Bhattacharya, Dr. Hema Rath, Dr. Aniruddha De to please come up on the stage to take the chairperson panel. And the session number 8 is echocardiography in the evolution of. We have the presence of the respected doctors in the chairperson panel. And now I will request the chairperson panel to take over this entire session.
Good afternoon, everybody. There is an interesting session on the echocardiography, particularly on the clinical cases and how you are behaving like that. Before that, there is an announcement that echo quiz be held by Dr. Santanu Sengupta at near about 6:30 p.m. So all are requested to come and participate, particularly the students and DM, DNB, MD, all students, and also the junior faculties. And there will be attractive cash prize for that, and that will be announced pre-launch session tomorrow. So now invite, without wasting the time as we are already running late, the first case is a dilated coronary sinus in a 40-year-old by none other than Dr. Satish Govind. I don't think he needs any introduction. Just over to Satish.
Thank you, Dr. Aniruddha. Namaskar to all of you. So, some great talks in the pediatric session, and to some extent, this talk will be an extension of that, but this will be a focus on the adult patient. So, let me first sort of, briefly give an overview of the actual coronary sinus, what exactly it is in terms of its anatomy and how it is formed. So you have this similar sort of a linear structure which you see, and it is actually an extension of that great cardiac vein. So it continues forward, and if you see the image below, there is something called as a Wissens valve, and beyond that it becomes the coronary sinus. And you have these four veins which connect to it and make the coronary sinus. You have the anterior, small, the middle, and the great. And at the ostium, you have the Thebesian valve, which is seen in a large number of patients. And the coronary sinus, you can see here having these entries of the veins coming in. So this is just to give you an idea as to how the coronary sinus looks inside, where the veins of the heart get into it. Now, a closer look at the Thebesian valve itself. So this is something which is seen in almost about 70% of the patients, but generally, unless it is very prominent or very thickened and very long, you don't generally see it, but it's always there. And it comes in various shapes and sizes, and has its own problems. So the EP people and the surgeons, they are the ones who sort of have to deal with this, and there's a lot of work going on because there are many challenges associated with cannulation getting into the coronary sinus. So this is just about the anatomy itself. Now, how does it look on echo? So you have this very small echolucent structure which you see where the arrow is pointed at the top, the Patterson long axis. So generally you might not even see even that much also, because sometimes it's so flattened and so collapsed you'll not see it. So that's where the position of the coronary sinus is in the long axis. And the next, what you do is you go to the modified view, and then again next to the IVC you see the coronary sinus over there, and then you can also view it in the apical 2 chamber and also the apical 3 chamber. So most of the times you tend to see it, and sometimes you don't, but these are the places where you see it. And traditionally we always looked at it, apart from the long axis, in the 4-chamber view. So the 4-chamber view, if you go for a classic 4-chamber view, you don't get to see it. You have to go a little posterior, tilt it, and then it sort of pops up as a echolucent linear structure over there. So this is how you sort of get to see the coronary sinus. Now, when it dilates, you get to see it as an echolucent structure, and then sometimes it is so echolucent and the walls are so thin, you tend to miss it, and especially if the window is bad. So be a little careful about it in terms of the long axis. And again, it's the same in the 2-chamber, 3-chamber. And when you come to the 4-chamber, sometimes when it is dilated, it has been mistaken for ASD, so we have to be a little careful about that. Now, when it comes to the dilatation itself, so let's sort of club the anomalies of the coronary sinus together and then sort of tease out the dilatation. So this is a very old classification, 1966, and to a large extent, this is, it keeps on getting quoted in the literature. So this is primarily focusing on the congenital causes. So here you have the anomalies. So the anomalies can be enlargement, it can be absence of coronary sinus, and then you have atresia of the coronary sinus, and then also hyperplasia. But today the focus is on dilatation. So I will sort of focus on this, and this again is, as I said, it is about congenital conditions. So here you have conditions where there is no left to right shunt, and then the second combination is where there is left to right shunt, but below that you have the submenu, we have low pressure shunts and the high pressure shunts. So the left to right shunt, without left to right shunt, you have the LSVC. This is the one which we commonly see and we diagnose most of the times. The other ones are very rare and sort of very low in terms of frequency, but now it is being picked up more and more because the interventions are more, the imaging modalities are being done more often, especially with CT. That's how it is being picked up. So this sort of, summarizes to many of the conditions, not all of them. So this is how the LSVC looks like. So the PLSVC, that's the persistent LSVC, that's the most common one. So you can see that it's the bilateral SVC, and then the left-sided drains into the coronary sinus. While the second image is about the hepatic vein. So you have the hepatic vein also getting into the coronary sinus. And then you have the IVC also coming from below, and then through the hemizygous, azygous, it can also connect into the coronary sinus through the LSVC. Then you have this ASDs, the unroofed, and then the regular ASDs. And then you have the complex congenitals, more, not relevant to our presentation, the common AV canals. And then you have this very, again, a very rare condition of the innominate vein also. And then the coronary sinus can open into the LA and also into the atria directly. So let us come down and then look at how the dilatation should be followed up in a patient, in a middle-aged adult, so a 40-year-old. So these people can come as asymptomatic, and generally they can, the dilated coronary sinus is picked up because of some other reasons. They can come for any surgery, routine echo, coronary sinus dilatation is picked up, or it will be multimodality imaging, like a CT is being done for some other reason. The imaging, the radiologist picks it up. Or it can be in the EP study itself while cannulating, or when they're trying to do the going into the coronary sinus, they have some problems, and then they find out there is some problem over there. And you have the patients can come with dyspnea on exertion, and they can come with fatigue, they can come with exercise intolerance, and also chest pain, syncope, palpitations. Palpitations are commonly due to arrhythmias, and the murmurs can be due to various reasons. And as I said, it can be incidental finding. So they can also be associated with other conditions. So the primary focus will be on other conditions, and these will be picked up. They may or may not be related to that, and it can be both acquired and congenital heart disease. So you see this coronary sinus. So now what next? So they can be asymptomatic, symptomatic, and the examination can be variable. So let us first look at it. So if there is, the first thing what we have to do is, when there is dilatation of the coronary sinus, the first suspicion is always going to be the persistent LSVC or the bilateral SVC or the LSVC. So it's commonly termed in different ways. So for this, you will have to do the saline contrast, and then the other conditions are the hepatic vein and the hemizygous, which I related. So in the LSVC, the first thing that we need to do is make sure that we go through this process of doing a saline bubble contrast study. And then usually the approach is always have an axis on the left antecubital. And then we are primarily looking to see the bubbles coming through the coronary sinus, and then it will sort of opacify the right atrium. So that's those are the images which tells you. You can see that the bubbles come into the coronary sinus first, and then sort of opacifies the right atrium later. You can also go a little suprasternal, and so many times you can actually visualize it directly. So this will confirm that there is LSVC, and most of the times the LSVC, the persistent LSVC will always be there. And this is just a pictorial sort of image of how it looks like. So you can see that it regresses in adults. later as the child is born, and then afterwards, if it persists, then it continues to be the persistent LSVC over there. Now, the dilatation, as I said, can be due to the hepatic vein itself. So this again can be accidentally detected. So remember that you can have hepatic vein coming to it. And sometimes during surgeries, they have noted that they can suddenly develop arrhythmias because they start tugging at the left hepatic vein, or the pressure goes down during the surgery. And that's when they start to look for it and they find the hepatic vein. And that is the cause for the coronary sinus dilatation. And then you can have in a hepatic vein, when it connects to the coronary sinus, the ostial part will be dilated, but the proximal will be of usually normal size. Then in the interrupted IVC, again, the sequence of the flow is through the azygos, and then into the LSVC, coronary sinus, into the RA. And again, if it is an isolated disease, and that is where it is accidentally detected, and it repeatedly comes at older age group, for some other reason, these patients come and even they have picked it up when they are going for transcatheter interventions, like even TAVI, they have picked up these sort of abnormalities. So they can come very late in life, and this has to be kept in mind. Now, the other one is now coming to the left to right shunt. So you have the left to right shunt, so you have the low pressure shunts. So in the unroofed ASD, and then you have the PAPVC. So you have one vein or two pulmonary veins going into the coronary sinus, and generally this again doesn't affect that much, and that's why they're present later in life. And then you have the ASDs which come later. The one is sort of trying to find out whether this patient has an ASD. You do an echo, and then along with the ASD, you find the coronary sinus dilated. So this can be ostium secundum ASD or even a sinus venosus ASD also. And then again, for the unroofed, you do the saline contrast, and that is the easiest way to detect it. And then the high pressure shunts. So you have dilatation due to, again, with left to right shunt, but these are high pressure shunts. So these are originating from the coronary arteries. And again, these are very sort of infrequent, and they come in various sort of ways and various combinations. So here you have the coronary artery fistula to the coronary sinus, and it can be right or the left coronary artery. And patients can come with syncope, chest pain, or any of those symptoms which are shown over there. And to a large extent, if one is alert, one can pick it up. And again, this depends on a good window, and then again the fistula size, if it is sort of reasonably good, and you can pick up the color flow, which looks a little unusual, and you can trace it. These patients can also present a little later in life with heart failure. They can present with MI, even infective endocarditis, or even rupture. So this again depends on the size and how it's sort of associated with other conditions also. So less common conditions where we still have to keep in mind is you can have a single SVC. There's no right SVC, but you can have a single SVC to the CS. And you can have both the right as well as the left going into the coronary sinus. So this again, you will find out when you give the contrast, you do it on the right side, you will not see it coming, but you'll see it only on the left side. These are again very infrequent and too rare, I can say. And the LSVC to significantly dilated coronary sinus, now again recently it is sort of coming more and more into focus, where it can actually cause inflow obstruction. So this is not sort of, it is sort of assumed that there is some sort of a cystic mass, but actually this could be a dilated coronary sinus. And this is usually, the inflow obstruction happens when there is in the presence of mitral valve diseases. Giant coronary sinus have been reported, and this again there is no sort of sizing, but the maximum size as far as the literature is somewhere around 4.5 centimeters to 5, and this usually seen in tricuspid valve diseases, and they can have thrombus inside it. And you can also have coronary sinus post stenosis also, and you can have diverticulum also. Now, non-congenital causes, apart from the congenital which I enumerated, it can be seen in the right atrial pressure. When there is high right atrial pressure, it again dilates. And also when the right atrium dilates, so not only just the pressure going up, and also the area going up, so that's when the coronary sinus dilates. And then you have stenosis of the tricuspid valve, and then the regurgitation, and then you have RV dysfunction. So whenever there's RV dysfunction, there's likely to be dilatation of some amount of the coronary sinus, and that's because of the RA pressure increase and the RA dilatation. And also it's been sort of now and then noted to be seen in heart failure also. So you'll frequently come across when you are looking, especially when the pressures have gone up and you're looking at the right side a little more carefully, you'll see this mild dilatation of the coronary sinus. So this is an example of non-congenital causes where you can see that you have a the coronary sinus which is sort of mildly dilated, and this is a patient with pulmonary hypertension with increase in right atrial pressure. Then there's an example of tricuspid valve disease. So you can see here a huge right atrium, and that in the long axis you can see the dilatation of the coronary sinus over there. And RV dysfunction, again, you get to see this opening which is there. So you have these are the various causes which you can see in the adult patients, congenital, non-congenital, and one can look at it in terms of symptoms when they present, or it can be incidental, where there's no hemodynamic significance, but it's picked up because some other disease is there, and sort of accidentally it is detected. And when they do have symptoms, it is usually the late onset manifestation as the disease progresses, and association with other conditions also. And again, the classification, just to keep it simple, so look at it. If you see in an adult patient, you see a dilated coronary sinus, is it congenital, is it acquired? And if it is congenital, look for the LSVC, that's the most common one. And what is the shunt? Is there left to right or no left to right shunt, high pressure, low pressure conditions? And look for any acquired causes, that is, you are ruling out the congenital causes and looking at RV dysfunction and high RE pressure. And the investigations, primarily it is echo, you can use saline contrast, 3D to some extent can be helpful, strain to look at the effects of the chambers when you have other sort of loading conditions which have dilated the chambers. And then TE to some extent, especially the coronary sinus, the proximal part can be very well seen on TE. And those are the other investigations which are available, which will complement the echo findings. So my final slide here with a message that it is echo is a first line test as far as dilated coronary sinus and trying to find out the diagnosis. So it is a very good tool to detect the presence of dilated coronary sinus. But beyond that, to find out what is the cause, it can have some limited utility, but maybe many a times you might have to use other imaging modalities. Thank you.
Thank you, Dr. Satish, for a very lucid and beautiful deliberation on this. I think because of the lack of time, you may have only one or two questions. I don't think there is any question is required. This deliberation is so lucid and details. I don't think that. In fact, I have no questions. If any one or two more question from the audience.
Should be the cutoff for calling it a dilated coronary sinus because it will measure.
Yeah, again, there are many, so not many, I would say, limited publications. They have looked at these coronary sinus. They have started from the ostium, looked at the length. So generally, if I have to sort of quote a number, not recommendation, these are not like guidelines or anything, just quoting from the literature. Length it can go up to around 4 centimeters. And the diameter, it can be somewhere around 1 centimeter, but it can go up to around 2.5 centimeters. It can dilate. But you have these sort of very bizarre sort of scenarios where it can go up to 4.5 centimeters also. So I think anything above 1 centimeter, I think generally you should start to look at it. But so again, we have to look at the body size. There's no data on that. So some publications say that even less than 7 normal size, between 7 to 9 is like a borderline, but anything above 9, you start to think that there is it's dilated.
Thank you, Satish. Now, the next case is, I'd like to invite Dr. Santanu Sengupta. Is a 52 years old lady with the breast cancer has received 2 cycles of anthracycline chemotherapy. The patient was mildly breathless on exertion, no previous cardiac history. Oncologist wants to know if it is safe to continue the anthracycline or not. In fact, we are very indebted to Dr. Santanu Sengupta because this speech was supposed to be delivered by Dr. Somesh Srivastava, who is unfortunately is not able to come. And in the last hour, Dr. Santanu Sengupta agreed to deliver this lecture. Thank you, Dr. Santanu. Over to you.
Yeah, thank you, Dr. Anirudh. So, can I have the slides? So, this is a clinical scenario which has been given to me about a patient on CA breast, which HER2 positive on trastuzumab therapy. But I think before that, I would like to give a slight overview how to manage the problem of cardio-oncology, and I'm going to make it very simple to understand how does echo imaging helps, and also the use of biomarkers, and then we'll go ahead. I do understand that I have only 15 minutes, so I would like to wrap up in 10 minutes. So, you know, the malignancy and cardiovascular disease is a big problem, and they go hand in hand. They are the two leading problems, and a patient can have malignancy, cancer for the first time, but can subsequently develop a cardiac problem because of either cancer induced or anti-cancer drugs causing cardiotoxicity, or the patient can have a pre-existing cardiovascular problem and can have malignancy, and the problems can get deteriorated further. Remember, the cancer drugs, all anti-malignant drugs can cause all kinds of problems. You can have LV systolic dysfunction, they can cause arrhythmias, you can have thrombosis, pericarditis, myocardial ischemia. Let me tell you, till now, for the cancer therapeutic drugs, they are not known to cause heart failure with preserved ejection fraction. So, diastolic dysfunction being caused has not been in the guidelines. And the drugs which are implicated for causing this problems are this. So what I mean to say, every cancer drug can be cardiotoxic. And recently we see that a lot of newer drugs are coming. The more advanced the drug, the more cardiotoxic they are becoming. So it is very important for us to identify this entity, and the cancer therapy related cardiotoxicity, which is called CTRCD. CTRCD is basically of two types, type 1 and type 2. Type 1 is predominantly cumulative. That means as and when you are giving the dose, the toxicity keeps on increasing, and it is predominantly irreversible. And the best known example of drugs are adriamycin kind of group of drugs. And the type 2 is basically reversible, means that is dose dependent. So you give the drug, it causes cardiac problem, and then it reverses back. So our patient had trastuzumab therapy. So this is the drug. So it is dose dependent. Now, the reason oncologists prefer to have 3 or more drugs or 2 or more drugs is to minimize the cardiotoxicity of a single drug, so that more drugs are not, a single maximum dose is not used. Now, coming to the type 1 drug, it is known that if you give adriamycin to a dose of as high as 400 milligram per meter square in a patient over a period of time, the chances of cardiotoxicity are almost 5%. But if the dosage goes to around 700, almost 50% of these patients are going to have problems. Now, we have to understand that can you prevent it, and there is lot of work going on, and what drugs you can prevent. I will come to that later on. But the major drugs which have been shown to be helpful are ACE inhibitors, carbidiolols, statins, the big Sucker trial which Tom Marwick has been doing, and with the use of GLS I'm not going to that, but let me tell you that you have to go for an early detection and identify. So this was the consensus statement which came in 2014. It's almost 10 years by Joseph Splana, but over a period of time, a lot of work has come up, and he has tried to simplify how to identify. So the best way to identify cardiotoxicity is either by going for a biopsy, which is very difficult. You can go and echo, and you can do for biomarkers or do for multimodality imaging. For us, the day-to-day practice should be echo and biomarkers. So I'm emphasizing that every patient of cardio-oncology being referred to you should have an echo. Also, you should give a prescription of anti-proBNP and troponin for this group of patients. Now, I'm just going to go too fast. So, the way to assess echo in this patient is all standard views, but you should also have a GLS in this group of patient, and identifying that you have to report the loading condition, the heart rate, blood pressure, and as Dr. Mohan today mentioned about the the SpO2 in this group. Now, this is the standard thing which should be needed, which is needed to be followed. Always measure LV ejection fraction in all patient coming for a cardio-oncology consult. You have to use biplane Simpson. M mode is not there, but if you have a 3D facility, 3D ejection fraction scores beyond LV ejection fraction by biplane Simpson. You have to give the volumes. You have to add a biomarker in every consult. You have to give the loading condition, and all patients of cardio-oncology consult should have a GLS, that is global strain assessment, done. So this is mandatory for all patients. And how to get a review, I'm going to tell. You can always consider CMR if there are selected group of patients, not always. Now, as I said, that ejection fraction should be done by a biplane Simpson. So whenever you are following up a patient, the echo should be done on a same machine. Let's say you're doing on a G machine, so it has to be done on a G machine. So in the reporting system, you should set that this is the assessment done on a GE Vivid E95 patient. So it has been recommended that you should not change the machine which you are using, and preferably the same operator should also do in subsequent patient. Now, so what is CTRCD? That is cancer therapy related cardiac dysfunction. So this is an entity, and this has to be identified. So it is defined as a decrease in the LV ejection fraction by 10 percentage points to a value of less than 53%. So what does it mean? Means that first time the patient comes to you and he or she is going for the first dose of any chemotherapy, and his baseline echo by biplane Simpson is 59%. So the next time when he or she comes, whether she gets adriamycin, trastuzumab, that doesn't matter. If the echo you are telling that EF is 56% by biplane Simpson, it is not CTRCD. 59% is the EF. Then the second value, if it is become 53%, there is a decrease of 59 minus 5.9%. So if the decrease in the LVEF is more than 10 percentage points, you have to mention CTRCD. But if you see that the second time when you do an echo, if the EF is 51%, it is an established CTRCD. So anything less than 52 is bad. That's why it is so specific that you have to do a biplane Simpson and not M-mode imaging. And they have also defined the reversibility as reversible, partial reversible, irreversible, or indeterminate. So I'm not going to details, but remember this 10 percentage points for identifying ejection fraction by biplane Simpson. And this has come up, why 53%? Why 52 and below is bad? Because of lot of work which has been done over a period of time, where they have seen that anything less than 52% in a patient having cancer chemotherapy are associated with poor outcomes. Lot of work about reproducibility. Now the second thing is looking at the strain imaging, and we today saw usage of global longitudinal strain. Regional strains are not valid. Circumferential strain or radial strain should not be done. It is only global longitudinal strain which is needed, and this is how we do it. We have shown it. So here they have identified that if the ejection fraction is 60% and above, it is considered normal systolic function. But if the EF is going less than 52, it is abnormal. But if the EF is in between, then you start looking at the GLS, and these are the value. So if the GLS is normal is minus 19, anything more minus 20, minus 21 is good. But if the GLS is minus 18, 16 to 18 and less than 16, you are identifying that there is some problem going on. So the cutoff is minus 16 for CTRCD. Remember, anybody having an EF of 59% or 58%, but the GLS is minus 14.7, you have to be careful. So what message do you give to the patient, to the oncologist? Sir, this patient is on an adriamycin. I am seeing that first time the EF was 60%, now it is 57%, but the GLS is going down. Please, what can you do? So he will do, maybe they will change the chemotherapy agent, or maybe they will give they generally delay the therapy by around 7 days, and then they send us back. And we have to start them on all anti-heart failure treatment like ACE inhibitors, ramiprils, and statins. So we have to give them. Role of ARNI is being evaluated in a big multicentric study, and I think the results are going to come up. So this is how you treat. So this was one patient before chemotherapy, it was minus 18.5, but after a dose of adriamycin, it came to 16.5. So you can still continue with the drug. But this patient, initial was around minus 19.5, but subsequently the GLS was minus 10.1. So this is bad. This patient has already established CTR/CD, and we have to give it to the oncologist that you have to be identified, and they should be knowing of this thing. So it is important that you identify this problem. One more thing, they have said that in follow-up of CTR/CD, for follow-up of CTR/CD patient, along with LV ejection fraction, you can also look at the GLS. So if the first GLS is minus 20%, and the second GLS before the second chemotherapy agent is minus 15, so there is a more than 15% relative reduction. So if more than 15% means it is going down by 15 into 3%. So there is a problem in the, but if the reduction is less than 8%, relative reduction, then there is no problem. So always try to have LVEF and also have GLS in these patients. So this is the final cutoff. So do a biplane Simpson. If there is a drop of more than 10 points by LVEF, if yes, it is an established CTR/CD. But if there is no drop, then go for a GLS. If it is less than 88%, there is no evidence of LV dysfunction, subclinical. But if it is more than 15%, LV dysfunction is present with EF ejection fraction being preserved. So this is a broad way of doing it. Now the question comes, what is the role of troponins, biomarkers? So before that, I will tell you that this was the paper which came 3 years back, a very important time, that when should you ask for an echo? When should you ask for a biomarker? The answers are here now, and these are going to be incorporated in 2025. So Georges Plana is coming out with one consensus, is a very close friend. So these are the suggestions. So if a person is on anthracycline, you should use ASVD protocol of cardiovascular risk. So we know that who is a low risk, who is a high risk, or a medium risk. Let's say he's a high risk patient. Then at baseline, all patients before the start of chemotherapy agent should have an echo and a biomarker. Biomarker means you should have a troponin and proBNP, and every alternate cycle till the 4th cycle, you should have an echo and biomarker, then every 3 months and after the 12 months. So this is about anthracycline, which is a type 1 cardiotoxicity. It is irreversible. But for trastuzumab, our patient, this is slightly robust because it is dose dependent. You again divide them into low risk, medium risk, and high risk. And once let's say if you're high risk, you should have baseline, and then you have every alternate till you have, it is almost 6 months. Every alternate cycle, then 9th month, the 12th cycle, 15th cycle, and after almost 3 months. So the point which I will tell you very briefly is that you can broadly tell your oncologist that get a baseline echo, also a marker, NT-proBNP and troponin, and ask the patient to come every alternate cycle. This is the broad way of looking at it. And remember, the biomarker monitoring is very important. So the two things which you do not to do is NT-proBNP and troponin. So if NT-proBNP and troponin both are negative, there is no myocardial injury, there is no condition. But if the NT-proBNP and troponin both are positive or higher, there is a condition, there is an injury. If NT-proBNP is positive, troponin is negative, there is condition, but it is because of stress, but there is no myocardial injury. Myocardial injury is caused by adriamycin. They cause injury. But if the NT-proBNP is negative, but the trop is positive, this is adriamycin. So this is kind of workup you should know. You should know the baseline levels of your lab. It should be consistently done at one lab. For our lab, NT-proBNP cutoff is 125 in my lab. Troponins are around 19. So you should know your lab. You should educate every patient. Every patient should know that they should get by LV ejection fraction by biplane and GLS. So one of all my patient and comes and tell, sir, मुझे मेरे heart का GLS करना है. I want to get my GLS. So they are educated. You have to educate them because that is very important. They know a lot of drugs. So let me conclude that cardio-oncology is a big problem. We need to have an early detection. The notion is we should know about it, but I think we should also tell our onco friends and should make them aware. Thank you so much. Any questions?
Yeah, I would like to ask one question regarding the first cycle of chemotherapy. After how many days, or just prior to the next cycle, the echo should be repeated, as well as other biomarkers. And another important thing is usually after the first cycle, the oncologist, if it is in a different center, he refers the case to the cardiologist whether the next cycle of chemotherapy can be given. And if so, after the first or second cycle of chemotherapy, the ejection fraction as well as the GLS is going down. So what should be advised, whether to avoid the anthracycline or such chemotherapeutic agents?
See, when to do it? The first question. So there are strict protocol. Baseline, after second cycle, after fourth cycle. So make it very alternate. Let's say they go up to 3 months. After that 3 months, you go 6 months, 1 year. This is for chemotherapy. I'm not talking about radiotherapy because that's not the question. Now, the second question was, what will you tell? Let's say you identify that the LV ejection fraction has gone to 51%. You will have to write to the oncologist, call him up and tell them. Most of the time, oncologists are in the other centers. First of all, start the 3 drugs, ACE inhibitors or ARBs, beta blockers, there is carvedilol and statins. And tell that this patient is going on for this problem. You cannot stop cancer drug, because if you stop a cancer drug, the patient is going to die of malignancy. So either they will delay the same drug or they change. So leave it to them. You cannot influence what they want to do. We are not oncologists. We have to tell them that there is a problem which is happening. Educate them. Tell them. The problem which I face in my place, maybe you, I don't know, the oncologist will only send it for the first cycle and the patient comes after 8th. That is a problem. So I think we need cardio-oncology meetings where we train them that this is needed. Yeah, she has.
Thank you, Dr. Santanu Sen.
She has one question. Yeah, please go ahead. I cannot.
Showing that when NT-proBNP will be positive, when NT-proBNP will be, troponin will be negative, all those permutation combinations. My question is that under certain inflammatory conditions, is this possible, like the same thing that you showed in this, what happens in chemotherapy? In certain inflammatory conditions such as Kawasaki disease and so on, which we see more prevalent in pediatrics, is this thing also the same?
Yeah, so I think what you are asking is NT-proBNP and troponin can be used in this condition. The answer is yes. So NT-proBNP is a marker of stretch, LV stretch. Well, troponin is a marker of myocardial injury. So I think we have to evaluate, and so if you are suspecting Kawasaki's, you also go for HSCRPs. So it's inflammatory markers. The point is, should we do it? Yes. What is the use? Prognosticate importance.
Thank you.
Yes.
Thank you.
Thank you for a very lucid presentation, sir. My question
So
is
there are
that
two questions. Sorry.
what do we do with the patients who come with heart? They begin with heart failure.
Yeah, so the point is, let's say the patient has LV ejection fraction of 40% and she has CA breast. Then she is already an established heart failure patient. You have to consider them as, you have to optimize them on a guideline directed medical management and tell the oncologist that they are established heart failure patients, but they need chemotherapy agents. So they generally titrate the dose according to their need. You cannot stop, because if you don't give an anti-cancer drug, they are going to die because of that. Yeah, you had one.
The targeted chemotherapy is done with the immune checkpoint inhibitors.
Yeah, so monoclonal antibodies, targeted chemo, they are highly cardiotoxic. They are also cardiotoxic. So what I'm trying to tell you, sir, baseline you should have a echo. Baseline you should have a TROP and pro-BNP to understand what is the status of the patient, because they can have an existing cardiovascular problem also, and follow them up.
So, hello. Is there any role of coronary angiography after first cycle or second cycle of chemotherapy, the LV from dysfunction? So is there any role?
Yeah, so I think the incidence of CAD in a patient. So as I said that you have to risk stratify by ASCVD score. And if you are thinking that this patient is having angina or angina equivalent, yes, that has to be treated. That has to be treated. You don't stop. So it has been seen that radiotherapy patients, cancer or chemotherapy or cancer per se can cause CAD. So you have to evaluate according to the presentation of the patient. Yeah. Thank you.
Thank you, Dr. Sengupta. Our next speaker, Dr. Devika Chatterjee, will speak about dilated RV on echocardiography in a 40-year-old female.
তখন তো এলো খুব এসে গেছে দাঁড়া the first slide. First slide. Okay. Thank you, Chairpersons, and good evening, everybody. I'm going to present evaluation of dilated RV on echocardiography in a 40-year-old female. Let me start my presentation with a patient. Again, she is 40 years, fatty female, presented to us with sudden onset shortness of breath in class 2 to 3 for 3 days. And she also complains of painful swelling of both her legs for 7 days. On examination, pulse was 80 beats per minute regular, BP 110/70. Both the legs were swollen and tender, chest was clear, there was a systolic murmur, ECG was within normal limit. On echocardiography, I got dilated RA and RV, as you can see very well. If you compare with the LV, RV is dilated. And not only that, if we look at the RV systolic function, it's reduced. It is reduced to the extent, you'll see the TAPC is 13 millimeter only. And not only that, if we look at the free wall of the RV, look at the basal and the mid portion, these are akinetic. On the other hand, the apex is contracting. So this is a very unique sign which we get in echocardiography in cases of acute pulmonary thromboembolism. This is called McConnell sign, where we get akinesia of the RV free wall with sparing of the apex. She had at least moderate tricuspid regurgitation with PH. So, from the history and the echocardiographic findings, our diagnosis was pulmonary thromboembolism. Her plasma D dimer was high. Venous Doppler showed multiple thrombi in popliteal veins. So, as per the latest guideline, diagnosis has to be confirmed by CT pulmonary angio, which showed multiple thrombi in both the lungs and a large thrombus in the left pulmonary artery, reaching towards the right pulmonary artery. So, this is a case where RV is dilated due to pressure overload. So, other than the pressure overload, RV may be volume overloaded, or it is the culprit might be the myocardium, or there might be some combination of these conditions. Now, let us see, there are many diseases which will give rise to the pressure overload, volume overload, or myocardial dysfunction. If we look at the pressure overload, as in this case, it was the pulmonary, the cause was pulmonary thromboembolism. So there is pulmonary hypertension, and which might be due to idiopathic cause, where we don't know the cause, pulmonary thromboembolism, secondary to congenital heart disease, secondary to left heart disease, or lung cause, or even the RVOT obstruction. While looking at the volume overload, you see the various types of atrial septal defect gives rise to the volume overload of the RV, along with that tricuspid regurgitation as well as pulmonary regurgitation. On the other hand, in myocardial dysfunction, you see various type of RV cardiomyopathies like ARVC, Wolff's anomaly, also the RV infarction, and terminal stage of the cardiac remodeling. So if a patient who is around 40 years female comes to us with RV dilatation, we should always we should approach to the patient with a thorough history and clinical examination, because it reduces the differential diagnosis. As you have seen, the list of the diseases causing the RV dilatation is very broad. So differential diagnosis is a broad thing here. In my case, the history of swollen tender legs with shortness of breath helped me to go to a diagnosis of pulmonary thromboembolism. Other than that, we also do the basic tests like ECG, chest X-ray, peripheral vascular Doppler, because these tests give us clue to the possible diagnosis. And then at the end, we do the imaging. We always start with transthoracic echo, because that is the point of care tool to us. Often we do the transthoracic echo for some other purpose, and we see that RV is dilated. And if needed, we go for transesophageal echo, and of course CT and MRI. All these tests form a vital link to the diagnosis. And we must remember that these imaging modalities are complementary. One imaging modality may not give all the information. We may need more than one investigation to come to a diagnosis. Now, when in echocardiography, we look at the RV, we must assess the RV starting from the size, then we go to the function. We also look carefully at the RV myocardium for its thickness, scarring, presence of aneurysms. And we do look at the LV and compare the size of the LV when RV is dilated. You see, normally RV is smaller than LV, and when it is dilated, it might look similar to LV, and when it is hugely dilated, it looks bigger than LV and it forms the apex. We also focus on the interventricular septum, because you see, when there is pressure, the pressure in the RV exceeds the LV pressure, the septum becomes flattened and it moves towards the LV, giving a D shape to the LV. Now, looking at the flattening of the septum, we may get some ideas about the pressure overload and the volume overload. In pressure, you see, in volume overload, the flattening takes place in diastole, unlike the pressure overload, which occurs in systole. We do measure the size of the RV from the RV focus view, RV OT measurement in the parasternal long axis as well as in the parasternal short axis, where we see the proximal RVOT and the distal RVOT. And we measure the RV wall thickness from the subcostal view at the point where the anterior leaflet touches the myocardium. We zoom it and measure the thickness. After looking at the size, we go to the function of RV. We must remember that in RV there is a longitudinal movement also. Unlike LV, LV has got mostly the radial contraction. On the other hand, RV has got a longitudinal function also. So we need to look at the longitudinal function by doing tricuspid annular plane, by measuring tricuspid annular plane systolic excursion, where we do the M mode across the tricuspid annulus, and we measure the distance between the lowest point and the highest point, because annulus moves towards the apex during systole and moves away from the apex during diastole. We do measure the systolic velocity from tissue Doppler imaging, and the cutoff value is 9.5 centimeter per second. We also measure fractional area change, which is the percentage of a change in area from diastole to systole, and the cutoff value is 35%. And we can apply the latest technologies like three-dimensional echo, where we not only get the RV volume, we get a whole lot of information about the RV, including the ejection fraction. So also the RV strain, you see, it has got a very good correlation with RV EF assessed by cardiac MRI. So this was discussed in detail in the morning. I'm not going into detail. And to end the examination, we also look at the right-sided hemodynamics. How is the PA pressure? We do look at the RVOT, whether there is any obstruction in the RVOT, and how is the pulmonary flow. And then we come to a diagnosis. Now after that, let us see some cases. Here is a patient who has presented with palpitation and SOB for 6 months. On auscultation, wide fixed splitting of the S2, ECG shows RBBP. Look at the right side, it's dilated. And if we look at the IS, there is a large dropout in the region of fossa ovalis. And as I put the color flow, I see left to right flow. So that confirms the diagnosis of ostium secundum ASD, which is a very common congenital heart disease occurring in 7%, and more commonly, it's more common in female. Around 65 to 75% cases are female. But a similar patient coming with same history and same auscultatory finding and the ECG finding, we do see RARV dilated, but in this particular case, I put the color flow, I don't see any ASD. Though the systolic function is well preserved, there is no obstruction in the RVOT. Now, this type of unexplained RV volume overload on transthoracic echo is an indication for transesophageal echo to rule out sinus venosus ASD. So as I do the transesophageal echo, see there is a large dropout in the uppermost part of the IAS. I'm at 0 degree, my focus is on the IAS, and I see left to right flow through that ASD. So it's a sinus venosus ASD. And while looking at the sinus venosus ASD, we must always look for partial anomalous pulmonary venous connection, because it's a common association occurring in 80 to 90% cases of sinus venosus ASD. So this is a surgical case, whereas the secondum ASD can be closed in the cath lab with a device. So we need to diagnose this sinus venosus ASD with transesophageal echo. Here is another case where there is a combination of RV volume overload and a pressure overload. A case of Epstein anomaly. Look at the tricuspid valve. The displacement is around 22 millimeter. The valve leaflets, the septal leaflet is plastered, and anterior leaflet is long, and there is a large coaptation defect. At the same time, look at the RVOT. The pulmonary valve is thickened, calcified. So as I put the color flow, in the tricuspid valve, I see a lot of tricuspid valve regurgitation, giving rise to the volume overload. And while putting the color in the pulmonary valve, I could see there is pulmonary stenosis with a gradient of around 55 millimeter of mercury. So this type of combination of volume overload and pressure overload are also present in many patients. Now let us see another case of RV volume overload in a 40 years female who came to the emergency room with a history of episodes of syncope and shortness of breath. ECG showed T wave inversion in V1 to V3. During the hospital stay, she had multiple attacks of VT and NSVT for which AICD was implanted, and my pictures are after AICD implantation. Now look at the RV. It's dilated. There is systolic dysfunction. Now let us have a look at the free wall of the RV and the apex very carefully. Look at the RV free wall. It's thinned out, it's bright, and if we look carefully, there are aneurysms at the apex as well as in the RV free wall. These features, along with the dilatation of the RVOT in the plaques and the short axis, with the ECG finding of T wave inversion, confirm the diagnosis of arrhythmogenic right ventricular cardiomyopathy. And of course, we confirm the diagnosis by cardiac MRI. You can see the aneurysms in the RV. This type of aneurysms are a major criteria for diagnosing arrhythmogenic right ventricular cardiomyopathy, a disease of the myocardium, where myocardium is replaced by fibropathy tissue, and initially it involves the RV, and in advanced cases, we may see the involvement of the LV. A genetic disorder, both the genders are equally affected. Females have a median age of onset of 44 years, and though she was 40 years, and males at 32 years, but clinical manifestations are much more frequent in male than female. Yet another case of RV dilatation in the 40 years female who presented in shock in the emergency room, and ECG showed inferior wall myocardial infarction. Look at the RV. RV is dilated, so also the RA. Look at the short axis view. The inferior wall is scarred and akinetic. In the two-chamber view, inferior wall is scarred. So it's a case of inferior wall MI. Along with that, there is RV infarction. RV has become thin, akinetic, with severe systolic dysfunction. So RV infarction often accompanies in 30 to 50% cases of inferior wall MI, and the clinical clue is hypotension, shock, as in my case, the patient came in shock with elevated JVP, ECG showed inferior wall MI, and right-sided chest lead showed ST elevation. And we have to be very careful because these echo findings are often transient and may not be visualized after 48 to 72 hours. So if we are careful, always we should look at the RV in all cases of inferior wall myocardial infarction. And another case of 40 years female who is a known case of mitral stenosis, now coming to us with RV dilatation. We see it's severe stenosis. The valve orifice area is only 0.89 square centimeter, both by planimetry and the CW pressure half time. And in four-chamber view, you see dilated area and RV, and look at the tricuspid valve. It's absolutely normal. There is severe tear, so this is a functional tear secondary to the left heart problem, and this tear has caused severe dilatation of the area and RV. There is a severe pH, and we must inform these in advance to the surgeon, a very important information that tricuspid valve leaflets are morphologically normal, but their annular dilatation has resulted in severe tear and enlargement of area and RV. The patient is in sinus rhythm. Look, it is because of the dilatation of the annulus which has caused the dilatation, the severe tear. So, RV dilatation due to secondary to the mitral valve disease as a result of tear is a common association with mitral stenosis. More than 1/3 patient of the MS can have moderate tear without any primary tricuspid valve leaflet anomaly, pathology. And as we know, tear begets tear, results in annular dilatation and distortion of the subvalvular apparatus. So all these causes increase the tear further and further. So to summarize, I would say that a wide spectrum of the disease can cause the RV dilatation in a middle-aged female. So we should start from careful history, clinical examination, and the basic investigations, and we come to a diagnosis with deductive echo and also with the help of other cardiac imaging modalities. Thank you.
Yes, ma'am, excellent deliberation. One thing I would like to ask is the TAPSE is a marker of RV function, but is it possible that TAPSE being normal, values normal, but still there is RV dysfunction? And the other thing is...
As in the morning, Sarah said if we give volume, the TAPSE value may rise, though there is RV systolic dysfunction. In the morning, we had a discussion in detail.
And one more thing, ma'am, you have quoted that RV size is usually assessed by seeing the LV size. If it is greater than the RV, then the RV is dilated. But it may so happen that LV is also dilated, as in case of dilated cardiomyopathy. So it may appear that RV is not dilated.
Yes,
so RV diameter is one of the...
Yes, yes, you have to measure it. But just qualitatively, you can see by looking at the LV that it's dilated.
Definitely.
And quantitatively, you will have to measure.
Instead of your 40-year-old lady, if you have a 40-day-old male with RARV enlargement and presenting with certain hypotension and cardiogenic shock without sepsis, what will you think? RARV enlarged,
Okay.
young boy.
I'll always think for RV cardiomyopathy first.
I think I would look for coarctation of aorta, severe coarctation.
Coarctation of aorta.
Yes. And
With
when the
RV
PDA,
dilatation.
yes, and PDA closes, then the shock develops. See, beyond the site of coarctation, if there is a PDA supplying the aorta, ductal dependent circulation, systemic circulation. And if the PDA closes, then you develop cardiogenic shock, hypertension. And RARV enlargement is an important cause is coarctation of severe coarctation of aorta. You have to keep that in mind.
Okay, thank you. And I haven't come across such cases.
Thank you, madam. Thank you, Dr. Debika Chatterjee, for the excellent presentation. May I now invite our next speaker, Dr. Abhijit Biswas. He will be presenting a case of 56-year-old man with enlarged liver and elevated JBP. Dr. Abhijit Biswas.
Pointer. Pointer. Very good afternoon, respected panelists and chairman sir, and respected audience. I'll be presenting a straightforward and a pretty rare case, and I've got a very few slides, but my stress is on the areas where what is recommended and what we usually do, and what are the false positive areas and false negative areas. Now, in our hospital, a patient was sent for an echo just on the second day of admission. A 56-year-old male presented with 3 months swelling of the abdomen and with pedal edema, with a mild shortness of breath, NYHA class 2, without any PND or orthopnea. He had past history of pulmonary cox, who was treated with full course of ATT. Now his hemoglobin was 15 and TC, DC, urea, creatinine, sodium, potassium were within normal range. His clinical findings, he had mild tachycardia, heart rate of 120 per minute, BP of 170, elevated JVP. Now, no definite X or Y descent was discernible at that time during examination in the echo room. The heart sounds were nearly normal, and on detailed history, apart from treated tuberculosis, he was being treated with furosemide and spironolactone for last 6 months. Now, his X-ray revealed he had a mild cardiomegaly and relatively clear chest wall, chest fields, and slightly blunted right costophrenic angle. And the upper lung fields were nearly normal, and there was no prominent veins. Now, his ECG showed low voltage tachycardia with STT changes. There was no alternance. And USG report was made available to us, and there was mild hepatomegaly with subtle echo texture. There was no cirrhosis actually, and there was mild ascites with GB sludge and a chink of right-sided pleural effusion. Now, we started doing an echo. We found that his pericardium was thickened, and there was a septal bounce and a relatively respirophasic septal movement without any pericardial effusion. So we thought that the patient could be having a pericardial disease secondary due to pulmonary cox in the past. So we started searching for a constriction, and we found that his both atria were dilated. Left atrium was more dilated, and on MOD echo, there was a septal bounce, which was almost clinching diagnosis on echo of CP in 2D echo. Now, the problem was there was no respirophasic ventricular shift in the echo, but there was definitely a septal bounce. On the 4-chamber view, he had a biatrial enlargement with a normal thickness of myocardium with normal morphology, with a pericardial thickening of nearly 15 millimeter. And there was normal morphology of mitral or AV valves, and there was no significant MR or TR. And the biventricular function was normal. Now, there was, as was expected, there was a small pleural effusion, and on subcostal view, on hepatic vein, on the inferior vena cava was plethoric without much change with respiration, and the hepatic vein flow Doppler revealed the diastolic flow reversal on expiration. Now, the Doppler in the mitral inflow showed 30%, more than 30% variation in the E wave velocity. And on the tissue Doppler study of the both mitral, septal and lateral annuli revealed that there was both annulus paradoxicus and annulus reversus. So the diagnosis, we straightforward went for a diagnosis of constrictive pericarditis. The surgeon was referred and he underwent a pericardiectomy. So it was a straight case of constrictive pericarditis. Now the things I wanted to present this case because 2-3 areas I want to stress on. One is we said thickened pericardium. Now by definition pericardial thickening should be defined as more than equal to 4 millimeter thickening of pericardium either on TE or on CT. Now we diagnose thickened pericardium on echo only on 2D. So this is a difference. I think we differ between theory and practice. Point number 2 is the dilated hepatic veins or engorged neck veins can be absent in nearly 20% cases if the patient is on prolonged diuretic therapy. So as the conventional book teaching is, if you don't find a square root sign on a RA pressure tracing, you give 1 liter of saline. Similarly, on the clinical point of view, we must remember that in a overdiuresed patient, the classical increased JVP or the venous pressure tracing clinically may not be evident. So we must remember these are the false negative signs. Now remember 2-3 things in the echocardiography and the Doppler study are for diagnosis of constrictive pericarditis are soft signs and hard signs. And this thickening of the pericardium on TTE is a soft sign. Dilated atria are a soft sign. And remember, in a restrictive cardiomyopathy case, the dilatation are much more compared to the constrictive ones. So remember, we should be keeping in mind these areas when we think of a constrictive pericarditis, because constrictive pericarditis patient will be coming to us telling that I had a TB treatment, I must be having a constrictive pericarditis. So once you start thinking of a CP, think of these false positive areas, remembering that every test or every sign has a sensitivity and specificity rates. Now, one thing we must remember, the second thing, the diastolic flow reversal sign should be in expiration. In a restrictive cardiomyopathy, the diastolic flow reversal sign may be present, but that usually occurs in inspiration. So this area is very important. Number 2, this increased medial mitral annulus velocity more than tricuspid lateral minus mitral annulus velocity. This increased velocity may be absent if there is mixture of constriction and restriction. Now this becomes much more theoretical. Even more important thing we must be remembering is the fact that mitral annulus calcification or mitral annular disease, which is so common in aged population, might be causing low velocity in the annulus, in the medial mitral annulus on tissue Doppler. So if you are getting a low mitral annulus velocity on a TDI, first see if there is a mitral annulus disease or not, and if it is causing the low velocity. Number 2, this inflow velocity, the high inflow velocity is a sine qua non sign for a constrictive pericarditis more than 25%. This is not present in any restrictive cardiomyopathy. But remember, just like overdiuresis masks the congestion of the vein, underdiuresis, that is a congested patient with a high LA pressure, may not have a high E wave velocity. Am I clear? If you don't have a high E velocity, first see if the patient is in failure or not, or if the LA pressure is high or not. If you think so, make the patient sit up or give a diuretic and ask the patient to come, then the actual sign appears. So this is again a false negative expression of a CP sign. Now, this is fairly a constant sign, but remember, this usually occurs in expiration. So, diastolic flow reversal of the hepatic vein is an expiratory feature, and if it occurs in inspiratory phase, then there may be a myopericarditis. Now, next point is septal bounce or a respiratophasic movement of the IVS is a hard sign for a diagnosis of CP. But what happens if the patient has already undergone a CABG or has an LBB? Then already there will be a paradoxical motion or a septal bounce. Then it may get mixed up or it may cause a false positive sign. Now, atrial fibrillation sometimes masks all the Doppler findings. In those cases, it is very difficult to diagnose, and you have to select the RR cycle to diagnose the case. Now, what are the diagnostic challenges? Now, restrictive cardiomyopathy, as sir was telling, you have to suspect a restrictive cardiomyopathy. Now, there are many states where restriction constriction gets mixed up, especially in a long-standing constrictive pericarditis. For example, if you are treating a patient of a constrictive pericarditis, not with surgery, only with ATD and a steroid, mild constriction, then how do you assess the response? Now, you assess the response either by hepatic vein size or IVC size or LA volume. Actually, what should be the guideline, I haven't been able to find out in the internet. Now, what happens after follow-up after surgery? Suppose the patient has undergone a decortication, the pericardiectomy has been done, that is both the visceral and the parietal pericardium has been excised. Now, how do you follow up the patient? Even after decortication, if the patient comes back with the same symptoms or diastolic dysfunction continues to remain, then you must think of a constriction-restriction mixture. Now, there are no large data, multi-center data, I haven't found any. There are one or two data from Spanish studies where they are saying that usually the systolic function starts to improve, but the diastolic function continues to remain the same for a pretty long time. But we don't have any idea or a data, but we must remember, even after the proper surgical treatment, even after proper diagnosis, the patient may remain same or the symptomatic. In that case, we must think of other uncommon diagnosis as a restrictive cardiomyopathy or a restrictive constrictive mixture. Thank you.
You have practically demonstrated very beautifully the features of the constrictive pericarditis and the difference with the restrictive cardiomyopathy. Only one point I have to add is that you have done all the clinical parameters and the echocardiographic criteria, but GLS is a very important differentiating point between the constrictive pericarditis and the restrictive cardiomyopathy, because basically constrictive myocarditis, even if there may be some muscle involvement, usually the GLS is preserved in case of constrictive pericarditis. Whereas in the restrictive cardiomyopathy, basically it is a myocardial disease. The GLS is bound to drop. So that's a very important thing always should do in the case of
very pertinent point, sir. We had a discussion among ourselves. Even Rajodda, I asked Rajodda what should we doing. We intentionally did not include GLS because I want to present a case with a constrictive pericarditis. Now, if you add a GLS, you will be having a normal GLS longitudinal score with a compromised circular score. Now, if you add a GLS, then it will definitely drag you to the definitive diagnosis. So we intentionally omitted that. Now, since you have raised the point about GLS, what about after post-operatively? Do you follow up with GLS? Sir, any...
No. Because usually it is preserved. So you don't follow up with the GLS with the constrictive pericarditis.
Okay.
Only in the differentiating point before the diagnosis is the very more important thing. Because it is usually preserved. So it will be preserved even after the surgery. So it's no point.
বলুন কিছু বলবেন না প্রদীপ
No. Any more questions? Okay.
Dr. Dev was saying needs to be said. GLS actually of late we are finding having great diagnostic significance and in reassessment following pericardectomy. Careful look at patients after Dr. Nitin Burkle published a paper 2 years back on a phenomenon called strain reversers, where the lateral wall 3-segment strain is significantly less than the septal strain, and the difference being more than 5% in absolute terms. We started looking at this phenomenon and we find that its diagnostic yield is pretty good. Something in the range of about 80% strain reversers. But in case you also have strain reversers of the RV free wall, wherein RV free wall normally is much more than the septum, but a situation where your RV free wall is less than the septum, then it becomes still stronger case.
Okay.
The other aspect is of following these patients after pericardectomy. An incomplete pericardectomy, according to us, is when strain inversus still persists, which actually means that the free wall is still plastered. You have not been able to free it up.
Right.
Unless you free it up from pericardium, you would have lower strains on this. So this is a very interesting thing what Dr. Dev was saying. Having been interested in this business of constriction for a long time, it's only for last 2-3 years that we have started seeing that strain is adding lot of value. The second thing which is of great importance, and I think we should look carefully, is shape of the left ventricle always changes in constrictive pericarditis of some duration, some standing, unless it is a few months duration. And we should carefully look at the shape. The shape tends to become banana shape. So I also saw
Sir, on echo.
On echo. Tubular tends to become tubular, and I saw your cases. It was going towards that side, and the LV free, the free wall was also getting, convex towards the septum.
Right.
So there were some subtle signs that the shape is changing.
Yes, sir.
So, thank you, sir. Thank you for your excellent presentation. And I'd like to once again thank all the speakers of this session for putting up their excellent presentation. And with this, we would like to end the session. And there will be a short break. Tea break? No. There is no break. So we will move on to the next session. Over to you.
I would like to thank all the chairpersons. I would request all the chairpersons, the speaker to please, sir, I will request you to please be in the middle of the stage for a picture perfect moment. I will request, sir, all the speakers of this particular session to please be in the stage so that we can have a picture perfect moment. We move on to session 9, which is a severe aortic stenosis in a 80-year-old. And for this particular topic, may I have the presence of the respected doctors in the chairperson panel, Dr. Shubhanan Roy, Dr. Prakash Hajra, Dr. Saroj Mondol, and Dr. Shorat Das. And till the time we are having the presence of the following dignitaries here as chairperson panel, I will take this opportunity to announce two very important things. First, the participants of the Echo Quiz to please stay back as we are running little bit late. We will have the quiz and we have some amazing prizes. So the participants for the Echo Quiz, please stay back. We only have 2 more sessions to go. And the second important announcement that I have is delegates who are staying for banquet dinner, kindly collect the pamphlet from the registration desk. Please, I will request all the delegates who are staying for the banquet dinner, please kindly collect your pamphlets from our registration desk. We will have Dr. Shubhra Banerjee, Dr. Prakash Hajra and Dr. Saurabh Dash as the chairperson of this particular session, severe aortic stenosis in a 80-year-old. So I would now hand over the session to our respected chairpersons.
Hello. Okay, the first speaker for the session 9 is Dr. Aniruddha De. He's going to speak on echocardiographic assessment before TAVR.
Yeah, good afternoon, everybody. It's my proud privilege and also a little scared because I'm speaking before a doyen of cardiology, none other than Professor J.C. Mohan. Anyway, I will try my way to speak about the echocardiography because in a patient before going to TAVR, because he will be speaking on the assessment by CT. See, any primary indication for surgical or percutaneous treatment of aortic stenosis now very made simple. Why? Because if it is a severe, really a severe aortic stenosis, then we have to look for 2 things. One is the symptoms, whether it is symptomatic or not. Second is the LV function. LV function means not only the LV ejection fraction, I means we have to do the GLS also. Because I'll see in the later slides. If the patient is severely symptomatic AS, irrespective of LVF, we have to do something. Or it's a severe AS with diminished LVF, including the GLS I'll talk later, irrespective of symptoms, we have to do some intervention. Now, imaging in patient undergoing TAVR is only 3. One is the CT, fluoroscopy, or the echocardiography. But still the echocardiography, why is in the top? Because this reason. Why? Because before TAVR, though CT chase is the primary means of TAVR valve sizing, there are many primary reasons for echocardiography because of establishing the diagnosis, severity and subtype of aortic stenosis, and the secondary means for TAVR valve sizing. And during TAVR, though fluoroscopy is the main guide, still echocardiography, again there is a primary means of assessing for paravalvular leak, overall valve function and the possible complication. But look at the after TAVR procedure, no one, only the echocardiography. Because there is the primary means of assessing the prosthetic and overall cardiac function. So there are many valves available, commercially available, but most important nowadays are 2 only. Either it is a balloon expandable valve, that is the Edwards Sapien, or is a self-expandable repositionable valve, that is the Medtronic Evolute Pro. The Boston Scientific is not now retired. Now, what is the role of EchoPAT to the TAVR? First is to establish the severity of the aortic stenosis and the subtype of aortic stenosis. Also assess the LV function and assist in TAVR valve sizing. Aortic how to look at how will you look at this really a severe aortic stenosis? We have to find first the peak gradient, then of course the most important, the mean gradient. Then by the continuity equation, you determine the aortic valve area, and of course it has to be indexed, and the velocity ratio. Now, there are 10 points to look out before the TAVR by echocardiography. Number one, to confirm the severity of the aortic stenosis. Say, for taking an index case, this is the case of severe aortic stenosis. You first look at the parasternal long axis view with or without color, then look at the short axis view. You have to do all the views. Then look at the apical 5-chamber views and with or without color, and then apical 3-chambers view, and put the Doppler to find out the maximum velocity and the mean velocity. Sometimes these conventional windows may not be able to show you the maximum velocity. Then you have to resort to the right parasternal view to give you the maximum velocity. Anyway, you have to find out here in this patient, I have done the GLS also. Why I'm telling you? Because this patient, the GLS also is reduced in the tune of minus 12.7%. Why I'm telling is that the patient with the severe AS and the preserved LVM, GLS is reduced mainly at the basal LV segment. Higher LV mass and the relative wall thickness, there's a lower GLS. Anything GLS is more than 70%, we know that excellent 5-year event-free survival. But if GLS is low flow, low gradient AS, provide better prognostic value during dobutamine stress echo when compared to the rest. Longitudinal function of the basal segments of the anterior wall and the ventricular septum are more affected because amount of fibrosis and hypertrophy are maximum in this segment. So what's the recommendation? Recommendation is that patient with the asymptomatic severe aortic stenosis with GLS worse than minus 16%, along with other risk factors. What are those? Either high calcium core, I'll come later on CT, or the myocardial fibrosis detected by AMRIA. MR may be considered for intervention. So not only you have to diagnose the severity of the aortic stenosis, you have to find out the class type of aortic stenosis. Though majority are high gradient aortic stenosis, there are 2 other varieties, that the low flow, low gradient, and the paradoxical low flow, low gradient stenosis. Why it is important? Because from the partner 1 trial, the low flow, low gradient severe is there is a lot of prognostic value in compared to the medical management and the surgical management in the high risk and inoperable patient. So there are 3 important cases we normally deal with. What is that? This is I called it high flow gradient, high gradient stenosis. That is the stage D1, where there is a Vmax is more than 4, mean gradient is more than 40, and the AVA is less than 1, with index AVA is less than 0.6. And second is the low flow, low gradient, where LVF is less than 50%, typically stroke volume is less than 35, AVA is less than 1, Vmax is less than 4, and mean is less than 40. But if you do the dobutamine stress echo in this case, it will rise up to more than 4 meters per second, but the AVA remains less than 1. And the last is the paradoxical low flow and the low gradient stenosis, because here is a severe leaflet constriction, severely reduced leaflet opening, but LVF is more than 40% with the low stroke volume, AVA is 1, less than 1, Vmax is less than 4, but mean is less than 40. Assuming SBP is less than 140 millimeter of mercury in the correct measurement, where calcium score is the more important. So if we get LVA more than 50%, straight away find out the calcium in the CT score. If less than 50%, do the dobutamine to find out the flow reserve. Calcium score is severe AS is likely in male is more than 2000, in female more than 1300 or 1200. I don't think I have to explain the criteria for AVR. I'm skipping this slide. But as this patient is more than 80 years old, there have to be surgical risk, not higher prohibitive. See, if it is more than 80 years old, TAVR is the class 1 indication. And another thing you have to look at is the life expectancy with the acceptable quality of life more than 1 year. If it is present, valve and the vascular anatomy is suitable for TAVR, then do TAVR, because it is a class 1 indication. Now, when we do the severe aortic stenosis, another important caveat is there. They properly measuring the LVOT diameter, because I'm stressing in this point why. Where to take should we measure? So there are different areas, and you know the LVOT shapes are also different. You see, the majority though is hourglass type, then maybe cylindrical and the funnel type. So what is the recommendation at the moment? Recommendation is that you measure the plane that bisects the right coronary cusp hinge point anteriorly and the interribulate triangle between the left and the non-coronary cusp. I'll give the example. And measure the LVOT at the aortic annulus, not 0.5 to 1 centimeter below, because these will give the false result. And the next is that the plane that bisects the larger diameter but exclude the calcification. By that you can calculate the predicted LVOT diameter and of course the DVI. So here is the example. Which one is the correct LVOT diameter? Of course not the upper one. This is the lower one, because what is that? In the lower one you can see that the upper plane, that is the anterior plane, is bisects the right coronary cusp, and the lower plane, that is the interlibulate triangle between the liblet of the left liblet and the non-coronary cusp. So by that you can measure properly the LVOT diameter and the LVOT area. Not only the LVOT diameter, LVOT pulse wave Doppler has to be taken very carefully, otherwise AVA calculation will be wrong. First it will be laminal flow. The small sample volume, reduce the gain setting, and of course the position in such a way either you not get opening of the closing click. So though multimodality imaging is the best and MDCT is the primary modality in the determining the device sizing and the assess the iliofemoral vessel, there are the three other important things to look at it. So this is a summary slide for how to see this, whether it is severe or not. So that way you determine the severe aortic stenosis both at the LVOT and the aortic valve area, and then calculate the aortic valve area and also the dimensional index. So to summarize that, for aortic stenosis, the systolic velocity must be evaluated from multiple transducer position, apical, suprasternal, right parasternal, wherever may be, and at least one clear envelope must be obtained. So this is first point. Second point is that to exclude the presence of sigmoid septum, because the basal septum hypertrophy may lead to balloon migration when using the balloon expandable valve. So if you get this type of pictures, be very careful, or in the 3D, this type of picture, you have to be a little more careful. Third point is the aortic calcification. Severe asymmetrical calcification of the aortic valve liblets may result in incomplete expansion of the valve and results in paravalvular regurgitation. So if you get this type of patient, you have to be a little more careful. Number 4 point, to exclude the bicuspid aortic valve, because why? There are the two reasons. BAV is not preferred usually because of the higher incidence of PVL due to the elliptical opening having two holes on either side of the prosthesis. And second is the association with the aortopathy, more incidence of vascular complication. So if you get this type of valve, a little more careful. So that should be always kept in mind before doing the procedure. Number 5 point is the mitral valve assessment. Not only the mitral regurgitation, of course, the mitral stenosis also. Why? The aortic annulus is in very close proximity to the mitral valve epidesmic, the aortomitral curtain. So placement of the valve a little low in the LVOT can encroach upon the AVML. Moreover, the dense calcification within the aortomitral curtain or mitral annular calcification may increase the risk of paravalvular regurgitation due to asymmetric expansion of the valve. So if you get this type of calcification extending up to the anterior mitral liblet and giving rise to the mitral stenosis, and that can be confirmed in the 3D echocardiography, you have to be a little careful. Moderate and severe MR is seen up to 48% of the patient undergoing TAVI. During implantation, the guide wire of the delivery catheter may interfere with the mitral subvalvular apparatus and worsen the degree of MR. So, worsening MR is included in the differential diagnosis of acute hemodynamic instability during implantation. And as such, the operator should be aware of any baseline mitral insufficiency or stenosis. So, this is the case of, you can see, is a severe aortic stenosis, but you have to look at the mitral valve that because this patient is also having moderate to severe regurgitation. Number 6, to exclude the LV thrombus. Left ventricular thrombus is a relative contraindication to TAVI, and this should be excluded prior to the procedure. See, this is a patient of aortic, severe aortic stenosis with LV dysfunction with the apical thrombus. So you have to be careful before embarking into the TAVI. Of course, this is very easy to diagnose. Sometimes you have to resort to the contrast to find out the apical thrombus. Number 7 is the coronary ostia. To measure the distance from both coronary ostia to aortic annulus by utilization of the 3D TLF software, echocardiography can identify the risk for possible coronary obstruction. So this is best can be done by the CT, of course, Professor Mohan will tell, but it can be done also by the echocardiography fairly accurately. Number 8 is the aortic. I'll finish within a minute. For acute measurement of aortic annulus, minimum and the maximum for choice of proper size of prosthesis that we know. Here is the CT is the main armamentarium, because you know the cross-sectional CT will give the best. 2DT, no. 3DT we explain, and particularly the multiplanar reconstruction can give this to fairly accurate if we really know the aortic root anatomy. Because the ventricular aortic junction is not actually the aortic root area, not aortic annulus. It is the hinge point junction of each iliblate in the imaginary virtual ring is the main area. So there is a recommendation of the 3D echo, because particularly in a patient with, not in the routine case, iodinated contrast is absolutely contraindicated. Alternative imaging include the magnetic resonance imaging for vascular strictures or transesophageal echocardiogram. So here you can compare with this 3D, it is fairly accurate. Number 9 is the choice of axis. T help to choose the proper axis. Of course, not the iliofemoral one, that is but the presence of the mobile plaques and thrombi in the descending aorta and the aortic arch is a contraindication for femoral axis. If you get this type of mobile thrombus, you have to be very careful. You have to do both two perpendicular views of the both descending aorta and the aortic arch to exclude the thrombi or any ulceration, otherwise you will miss this type of things. And so this is my last slide. This is the pre-procedural imaging with the echocardiography. This is the summary slide, is that it can give you aortic valve morphology, confirmed pathology, number of casts, aortic insufficiency, volume distribution and eccentricity calcification, aortic valve hemodynamics, LVOT, extent and distribution of the calcium, sigmoid septum, and this another important fact is the dynamic narrowing that can be only picked up by the echocardiography. Aortoannular complex dimension, mitral valve, severity of the mechanism of MR, presence of mitral stenosis, severity of the ectopic calcification of the anterior liblet, LV size and function, right heart and the pericardial effusion. So my take home message is echocardiography is a key aspect of care in the patient undergoing TAVI. And the goals of pre-procedural multimodal imaging for TAVI include ensuring patient suitability, assessment of access site, selection of the proper valve, and developing a procedural plan. Thank you.
Thank you, Dr. Dey, for the excellent talk. And I think there could be a lot of questions on this, but we are really short of time. So at the end of the talk, if there is any other questions, probably we'll take it. Could I now request Dr. Mohan, please, to say to talk on what a cardiologist would need to know from cardiac CT.
Thank you, Chairperson, sir. Yeah. So the mandate given to me is to talk about TAVR recommended in 80 years male with aortic stenosis, what the cardiologist wants to know from the cardiac CT. So let us believe this is a hypothetical case who's 80 years old, hypertension, CKD, and has degenerative aortic stenosis. And because of CKD and 80 years age and also relative LV systolic dysfunction, you have decided that this patient is a suitable candidate for TAVR. Despite not having good LV function, the gradient can still be pretty high, like in this particular case, and estimated valve area is really quite narrow. So the issue, of course, is now that echocardiogram has been adequately performed by Dr. Dey, and we have got good amount of information, what additional information we are looking at from CT, cardiac CT. Dr. Day did go in detail that in relatively younger individuals who are low risk, SAVR is the treatment of choice. However, people who are elderly, who are moderate to high risk, the TAVR should be considered, maybe preferred. And TAVR actually helps you understanding the access anatomy better, the annulus better, and cornea anatomy better. Dr. Day did show you this slide that three things are important: echo, which has already been performed, CT, and invasive cornea angiogram. And why invasive cornea angiogram? Because most of these people have calcified cornea arteries, and behind the calcium you cannot assess the severity of the lesion, and hence an invasive cornea angiogram before doing TAVR is necessary in all cases to fix up the arteries in case these are cause of problem, because later on access may be an issue. CAD is common in 40 to 70% patients undergoing TAVI, and coronary coronary evaluation is commonly performed using a classic invasive angiogram. So we are not doing CT for CT cornea angiogram, and the reason I told you, because is currently not recommended by the European Society of Cardiovascular Radiology routinely for pre-procedural evaluation of coronary artery, as the investigated population is less suitable because of prevalence of extensive coronary artery calcification and cardiac arrhythmias for coronary CT. So what are we trying to, what kind of information we are trying to get in a patient who is ready for TAVR? Detailed intervention anatomy of the aortic valve complex, detailed anatomy of the excess vessels, vascular and non-vascular comorbidities. We can better define the risk of the individual and tailor our approach accordingly. So in short, what does CT provide? It provides suitability of the patient for TAVR, planning whether you are going to use a balloon expandable valve or self-expandable valve, which access you are going to take, and what would be your minimum or maximum precautions. It helps you in selecting the valve, I said, valve sizing, and that becomes important because echo is insufficient actually to decide what size of the valve we should be using, and of course the risk assessment. The questions actually in mind of intervention cardiologists are which access I should take to take the valve to the native aortic valve, and what are my chances of producing coronary obstruction, and how and where I should be doing prosthesis anchoring, and what are the chances of paravalvular leak, and how I am going to tackle these if this happens. So let us come back to this ATS gentleman with aortic stenosis. And I told you the first part of this story, we still will do an invasive coronary angiogram in this individual to find out the severity of coronary artery disease and to fix up any lesions which actually could be troublesome. Plus, of course, and I said the reason is because the later on access may be challenging. Not that it is impossible. It may be challenging, and sometimes, of course, we have to take precautions during TAVR to protect actually the arteries. So what are the things we are looking for? We want to find out whether the valve is bicuspid or tricuspid. And in a calcific valve, CT does a better job of telling cuspidity of the valve than echo. And why? Because the bicuspid valves are less suitable and less favorable results are there with TAVR, not that TAVR is not being done. Valve calcium score, that is important because not only it tells you the severity of the aortic stenosis, but it also tells you what are the chances of having paravalvular leak depending upon the extent of the calcium. Annulus diameter will tell us the size of the valve we are going to use. Asymmetric or symmetric calcium, Dr. Day did mention about that. That is also important from a single viewpoint of finding out what are the chances of paravalvular leak. Left ventricle outflow tract calcification is important, and this again is an issue which has been discussed. Annulus coronary height, because that tells you what are the chances of intra-procedural coronary obstruction and what precautions should be taken to protect the arteries, and also which kind of valve should be taken so that the coronary obstruction does not occur. Coronary anatomy and its origin, of course, are important. Vascular access anatomy, I said, and challenging configurations of aorta and suitability. Especially, you can't really find out how horizontal is aorta on echocardiogram, and you can't find out what, you cannot detect what would be your approach. And remember, the controlled oversizing of prosthesis in relation to annulus is essential for anchoring a sutureless prosthesis. So how much oversizing you can do will also be decided by CT. So general principle of pre-TAVI CT, you must get motion-free, high-quality images of the aortic valvular complex, ostia of coronary arteries and sinotubular junction. This typically would be achieved currently by at least dual energy source 128 slice CT, because you don't have to actually, remember one thing, many of these patients, beta blockers are contraindicated for multiple reasons. And if you use a dual slice 128 to 250, dual source 128 to 250 slice, you probably can prevent what you will call as motion related artifacts. And of course, combined with the large longitudinal coverage encompassing the entire aortic course between the proximal supraaortic vessels and the iliofemoral axis for access evaluation. You can do a single scan, but it is preferred actually to do in two different scans actually, the access site and also the cardiac one. So so typically how do you do it? You really acquire a typical scout views, and then of course try to get axial views, sagittal views and coronal views, which are standard views the machine can give you on. And then there are well-defined what you call multi-plane reconstruction views, depending upon what your algorithm is or what are you trying to look at. So here is this the same gentleman, and now if you quickly look at the whole of the aorta is calcified, you can see the calcification of the coronary arteries and calcification of the annulus. Now that you have got an idea, this is a patient of aortic stenosis who is actually right from the bifurcation of the aorta. You see you can see this calcification. Let me just get can I get the laser pointer? No, I'm not able to get on the machine. But you can see you would see the descending thoracic aorta down here in a moment, and of course here. That's the calcification in aorta, descending thoracic aorta, going down nearly circumferential, not circumferential, patchy calcification. So this is not something which will bother us. Much botheration will be how much is the calcium in the excess vessels and how much is the size of the excess vessel. We have to have a minimum of 5.5 millimeter size of the iliac vessel. Similarly, you have to look at subclavian and carotid, because sometimes you may use carotid or subclavian approach. So first thing actually to begin with is to get a non-contrast enhanced acquisition of the aortic root, using acquisition parameters identical to a non-contrast CT for coronary calcium score. These slices are 3 millimeter thick with a 120 kV. Purpose here is actually to get an idea about calcium score and extent of calcium without injecting contrast. And the first set is of course non-contrast. In the non-contrast, you want to get idea about calcium. Why do we want to do it? Because once you have injected contrast, the calcium scoring becomes a little difficult and also a little less reliable. So on your right side, you are, and also of course you want to find out whether it is truly tricuspid valve or a bicuspid valve. It has to be done when the contrast has not been given. The picture shown here actually is, you can look at the annulus, calcification of the annulus and the aortic valve. And when you cut an en-face view, multiplane reconstruction of the aortic valve, you know that this is lower down, this is a tri-leaflet aortic valve, and calcium is present in the free edges of all the three leaflets, and a little bit calcium is present in the commissures. Remember, native axial views are to be preferred for aortic valve calcification. They are more accurate, and of course you use extern units. So the first point is non-contrast for calcium score, and for severity, as Dr. Day said, for extern unit, more than 2,000 in men and more than 1,300 in women correlate with clinically severe aortic stenosis. And the frozen picture shows you how to actually, which area to use extern score. Wherever you see the attenuation areas of that kind, high attenuation areas, you have to get the extern score. A score of more than 3,000 in men and more than 1,600 women is considered to make severe AS very likely, but also a very high calcium score actually enhances the chances of post-ever paravalvular leak. So keep that thing in mind when you are actually looking at AU. Next, of course, is to get a retrospective or prospective ECG triggered CT of at least the aortic root, mandative and motion-free evaluation, and this is with a contrast. And now you want to actually assess the left ventricle outflow tract, annulus, sinus of Valsalva, sinotubular junction, ascending aorta, and coronary ostia. So the CT acquisition protocol is slightly different when you inject contrast. Now the slices thickness is 1 millimeter. The slice thickness 1 millimeter rather than 3 millimeter, and a contrast enhanced CT scan with a scan range of that at least extends from the subclavian arteries to the superficial femoral arteries at the level of femoral head is required. Now both scans may be obtained, as I said, from a single acquisition, but in most cases, two separate acquisitions during the same session are preferable. And that would give you the idea about the access as well as the aortic root complex anatomy plus the coronary end. So let us come to the aortic annulus. We know that in patients who have contraindication to contrast because of significant CKD, you may avoid doing a contrast enhanced CT, but in other cases where it is possible and you can safely steer the patient out of it, the measurement of aortic annulus is far better with CT than with even transesophageal echo. So what do? You actually, first thing is you get a short and long axis diameter of the aortic annulus. How do you first get the multiplane reconstruction? After having obtained a sagittal or a coronal view, you actually get what is called as aortic view. The aortic multiplane reconstructed aortic view can be obtained by two perpendicular axes, one parallel to the aortic annulus, one perpendicular to the aortic axis, and these will be separate from sagittal and coronal planes. Remember, because aortic valve is not parallel to the long axis of the aorta or parallel to the long axis of the ventricle. Once you have got, you are at the level of the aortic annulus, right side picture will tell you where to place the cursor, where to actually place the planes. Once you have placed the plane, you would get this oval structure. Remember, aortic annulus is almost always oval, it is not spherical. You would get short and long axis diameters, you can get perimeter, and you will get area. Systolic measurements are preferred and ensure correct double oblique annular plane orientation. That is the double plane orientation which we are trying to show on the right side. The right picture is trying to show you. And then from perimeter you can derive the mean diameter by the formula I have shown you. But currently all three things are being considered for choosing or deciding the size of the annulus. Mean diameter, perimeter as well as area. Perimeter means circumference. So all three things have to be taken in consideration rather than only diameter, which of course was first thing when the tower was discovered. You wanted only the diameter good enough to decide whether you will be using a 21 size, 23, 26 or 29 size valve. Currently you need all three, and that is why this all three should be reported, and a cardiologist expects that all these three values should be available. So where do you exactly measure? That also is an important point. The one where of course the two blue points are there is the exact place where you want to measure it. That is exactly where the annulus is. You can, the red line actually is at the supraannular location, and the yellow is in fact the infraannular location. Why is it so critical to measure aortic annulus? Because if you underestimate, there is a chance of migration of the device, periprosthetic aortic regurgitation, patient prosthesis mismatch. And if you overestimate, there are chances of underexpansion, annular rupture, and coronary obstruction. So in both situations, it's absolutely critical that you measure it correctly, and you need to have significant amount of experience of having done number of a few hundreds of such cases accurately. There are of course artificial intelligence enabled software available nowadays where the human beings don't have to do anything. It gives you the complete picture just by looking at the DICOM images. So periprosthetic AVR risks are because of large aortic annulus, undersized prosthesis, asymmetric cusp calcification. So we have to see cusp calcification uniform or not. In this particular 80 years gentleman, we did show you that the cuspal calcification is symmetric and uniform. So that is a good thing. LVOT calcification, we did see the non-contrast enhanced pictures that there was no LVOT calcification, which is important from multiple viewpoints. Prominent septal bulge needs to be seen, for which of course you have to do contrast. And of course, the other reason for the periprosthetic AVR is low valve deployment. So the critical thing is aortic plane view. You do multiple, as you do in 3D, you do in T, similar way you do multiplane reconstruction. Having obtained this voxel, data set of voxels actually, you can slice and dice the whole data set in any which way you want. And the way to do is not the conventional, as I said, axial, sagittal and coronal views, but in plane of the axis, in line of the axis, one plane going absolutely parallel and at the place of the aortic annulus another 90 degree to it, and you would of course start getting at different levels, you would get the LVOT, aortic annulus, supraannular location, sinotubular junction, and of course the maximum diameter of the sinuses. And you can move that cursor up and down to get the exact value. So you also have to measure the length of the leaflet, which is possible, and calcium at free edges, like in this particular case. So having got the aortic view, you need to look for cuspidity, whether it bicuspid, tricuspid or undefinable, valvular calcification, amount and location and distribution, subvalvular calcification present or not, location and amount, and quantification of valve leaflet calcification using Aston score. But the point as I was trying to make is that you have to have a correct approach how to do it. Bicuspid aortic valves, I said, are associated with low TAVR success rate and high rates of post-TAVR paravalvular leak. So it becomes important to define the cuspidity carefully. The next thing is, of course, to define the aortic sinuses better. This is typically done in sagittal and coronal views. You don't have to take any other a specific MPR obtained view. Height, width, distance from the annular plane to the coronary ST and diameter of the sinotubular junction all can be obtained typically from coronal as well as sagittal views. These requirements, of course, of all these differ from type of the tissue heart valve and of course the manufacturer. So these are the two views you are seeing actually on your left side. This is a sagittal view, on your right is the coronal view. And here, as I said, it is easy to measure not only the width of the sinuses or the width of sinuses, and of course the height of the sinuses at the going up to the level of sinotubular junction from the annulus, and you don't require actually specially reconstructed views for sinotubular junction width and height. Of course, from both these views, you also get an idea about annulus to coronary ostia height, and there is a particular way of measuring this thing. This needs to be understood. There is a lower edge of the coronary ostia and the upper edge of the annulus, which actually the distance has to matter. I'll show you. So this is actually the moving picture, but you would see the both sagittal and coronary the coronal planes coming up, and you will see the ostia of coronary arteries coming. You can freeze there and measure it. Remember, the measurements have to be done in systole, as I said. This is a convention actually. It's not that you have to definitely go by that. Leaflet characteristics. Leaflets longer than the coronary ostial height and sinotubular junction height have leaflet calcification masses that can be displaced into coronary ostia. All these are required because you want to find out what is the risk of coronary ostia obstruction. So leaflet length is actually easily measurable by CT. Coronary ostial height, as I said, you can use both sagittal and the coronal views. The height of the coronary ostium should be measured perpendicular from the annular plane to the lower edge of the ostium. As I told you, a height of more than 12 millimeter desirable to prevent coronary obstruction, and the manufacturer recommendation for minimum coronary height are 10 millimeter for Edward sapien XT and 14 millimeter for core valve. And information about this as far as the coronary height, coronary ostium height is concerned, not that easy from echocardiogram, although Dr. Day did show you some pictures. By and large, you have to rely more on CT. Sinotubular junction height, the height of sinotubular junction again can be measured both from sagittal and coronary view, and you can actually average that. A height less than 15 millimeter runs the risk of coronary obstruction. So here, of course, you may have to choose a balloon expandable valve in case the sinotubular junction height is less than 15 millimeter. The diameter of sinus of Valsalva should also be measured from cusp to commissure parallel to the annular plane. A diameter less than 30 millimeter may risk coronary obstruction, and this is an important point to be kept in mind. You might be deciding to prophylactically put wires in the coronary arteries, or maybe an unexpanded stent or a balloon right down, and then of course do maybe a kind of chimney procedure. So this is actually on left side is the coronal view, and on the right side you are seeing the sagittal view. In both views actually you can measure the height from the annulus to the coronary height, and of course sinotubular junction, the height of the sinuses and the width of the sinuses. We wouldn't go, this is just three videos. The lower down you are seeing a axial view, and up actually on your left upper is sagittal view, and the right upper is the coronal view. You don't have to do anything. These views actually will come automatically once you play with the DICOM data. Ascending aorta also needs to be measured. They showed you beautiful pictures of moving thrombi and of course the ulcerated atheroma in the ascending aorta. They all can be seen far better by, as better and as good actually by CT as TE can do it. And you need to find out amount and distribution of calcium, thrombus, ulcerative plaques and other findings, so that you can decide which patient you are going to protect the carotids under all circumstances, and what are the patients where you can avoid spending extra money on putting actually the guards in the carotid arteries. So the diameter of ascending aorta should be measured in its true axial plane at the level of the greatest width or at the level of the main pulmonary artery, as shown actually in the frozen picture. And we have already talked about these things. So why all this is required from a interventionist point? Because a self-expandable valve may be preferable in extremely oval-shaped annulus or a low implantation of coronary ostia. And a balloon expandable device can be considered when patients have a dilated ascending aorta or severely angulated aorta. This is an example of a severely angulated aorta lower down, and here of course the approach has to be different. And as I said that bicuspid aortic valve defined better by CT, horizontal aorta is seen much better, and you of course have to measure the angle, what is called aortoventricular angle. And if the aortoventricular angle is less than 30, that is the definition of horizontal aorta, and the approach is different. It takes a little more time and of course an effort to get into the annulus. I wouldn't go in detail, but this is how the perimeter, mean diameter and the area are used to find out which kind of self-expandable, which size of self-expandable valve, whether 23, 26, 29 and 31 can be used. Lower down are given the mean diameters, perimeter and the area. Access route, the access route could be subclavian or common carotid arteries, or maybe common or external iliac arteries, and of course the diameter of common femoral artery, wall characteristics, left ventricle apex as Dr. Day showed in ascending aorta, all need to seen for things which we have already described. I wouldn't go in the detail, I will skip this, and all I want to say in the end is evaluation of non-vascular findings also an integral part of CT report. This is can be found in up to 25% TAVI patients, because these are sick patients. They may have actually lung pathologies which you might decide not to do TAVI at all, because if there are pathologies which are going to shorten the life of the individual less than 1 year, you are not going to take this. So there are many pathologies which can be seen by CT, and intervention always interested, what am I going to do and spend money, is it worth it? So I will leave you with those thoughts, and in the end, all I want to say is that what intervention cardiology needs to find out whether the valve is bicuspid or tricuspid, what is the calcium score, what is the annulus diameter, perimeter area, calcium is symmetric or asymmetric, whether LVOT calcification is present or not, what is the annulus coronary height, coronary anatomy and origin, vascular access anatomy, are there challenging configurations of the aorta and its suitability for device implantation. Thank you very much.
Thank you, Dr. Mohan, for the very lucid presentation of quite a difficult topic. I think we will have one question for Dr. Mohan and one for Dr. Dey. Very quick, short questions, because we really are struggling for time.
Dr. Dey, you have elaborately described role of TTE, but there are certain comments I want to make, like amyloid aortic stenosis 30%, and how do you help us, a cardiologist, whether the patient has got aortic stenosis in amyloidosis, because in India the rate is 30%. Second, giving contrast, can it improve the paravalvular leak? Third, the fusion of CT versus CT plus echo can give you 5D images like virtual imaging. And the fourth is spontaneous contrast in the LA. Like if you have a spontaneous contrast in the LA and you have a low flow, low gradient kind of thing, the chance of embolism is also very high, because it may have thrombus there. And the last one is glass view, like, or Philips in the glass view. Can it improve the regurgitation part? So both of you can answer.
Yes, Dr. Dave.
Yeah.
A lot of questions, but
no, I can't remember the four questions.
Dr. Hajra can
confuse
Albert Einstein.
Dr. Hajra, please give me the first point. What is the first question?
Amyloid.
Amyloid. Okay. Sir, actually amyloid, everything has been discussed by Professor J.C. Mohan. That time you probably were not there. That's why amyloid diagnosis by echocardiography is sometimes very difficult. Because all the features, of hypertrophic cardiomyopathy, increased wall thickness, any other cause, with only with the echocardiography, even by the GLS and everything is may not be foolproof. So you might have to resort to other features like MRI and sometimes the pyrophosphate scan or any other biochemical markers.
So I was actually trying to show when you weren't here a very recent meta-analysis of 21 studies, more than 4,000 patients of aortic stenosis, where the PYP scan has been done regularly.
Yeah.
There was 12% incidence of ATTR, another 3% of other types of amyloidosis. So probably it may not be a bad idea to do PYP scan in every single patient of aortic stenosis undergoing TAVI, more so if it's a low gradient, low flow aortic stenosis. It's not a bad idea.
Yes.
Reason, it costs very little when you see the total cost of TAVI, but at the same time, you can actually explain the prognosis to the patient who is spending that much of money. And also many patients on borderline may actually not benefit at all and may continue to remain symptomatic, because the diastolic dysfunction is because of the stuff which is deposited in the extracellular space and not because of the aortic valve.
Right. So the glass view, does it help, the modern glass view, in quantifying the paravalvular leak and the role of ice and glass view?
The paravalvular leak during procedure or after the procedure, that is very important. If you do during the procedure, echo is the only guide, because you cannot do the CT and all this thing during that time. But after the procedure, again the echo is the main cornerstone for dividing the paravalvular leak. Because paravalvular leak by transesophageal echocardiography, in majority of the case you can do diagnosis and the extent of the paravalvular leak, either by the circumferential area or by the vena contracta by doing the multiplanal 3D construction. And of course, the CT can do also.
No, see, we have always the pigtail right there. We can always look for paravalvular leak. The question is, mechanism of paravalvular leak can be better defined by using intraoperative transesophageal echocardiography. How much is the leak coming, and whether you should expand with a balloon, or are you going to actually, because of the asymmetric calcium, accept this paravalvular leak rather than rupturing the annulus? Those are the things which one can actually decide better.
I think paravalvular leak, when you inject with the pigtail, if you inject less, you see less.
Yeah.
If you inject more, you see more. But we can cheat. But the echocardiographer can cheat the patient.
This is certainly, you are right. But if you know what, for ages we have known that the paravalvular leak is overestimated by TE and underestimated by contrast angiogram. And so it also depends, would have to find a balance. If in pigtail injection I don't find, or I find mild, probably I wouldn't take any action. I would not look for that kind of paravalvular leak by echo and try to actually overdo the thing. In the process, maybe I will harm the patient.
Right. So, great session. We should conclude because of lack of time.
That is a consensus.
T is not only for aortic stenosis, it's also for air.
Yeah, of
air
course.
is also for TAVR.
Yeah.
There are some valves which can be placed for air.
Certainly.
Also. Okay. Great talk. Thank you.
So we conclude this particular session. I will request both the speakers to please come up on stage so that we can have a picture perfect moment. And now we move forward with the session number 10, that is management of HFpEF in diabetes, Torrent by Dr. P.K. Hajra. We already have him here. And the chairperson of this particular session will be Dr. B.R. Nath, Dr. J.C. Mohan and Dr. Shobhik Kanjilal. So can we have the presence of the respectable doctors in the chairperson panel so that we can start off with the session number 10, and along with starting off session number 10, two important announcements. First being all the delegates who are staying for the banquet dinner, please kindly collect your pamphlets, and we will have the echo quiz just after this. So please participants be ready.
Right, I'll be very quick and brief. You know, the heart failure is the burning topic today because you have RNA and SGLT2. We have none other than Professor J.C. Mohan, who knows much better than me regarding heart failure and the usage of pharmacotherapy. There is polypharmacy nowadays. And there are 4 fabulous foundational therapy for all heart failure. with reduced ejection fraction. The very game of heart failure changes very much on ejection fraction, which is determined by the echocardiographer. So echocardiographer or the ejection fraction plays a very important role before implementing the guideline and choosing the heart failure therapy. So heart failure is divided into two groups mainly, either reduced or non-reduced. If it is less than 40%, simply reduced, above 40%, non-reduced. Simple, very simple, and there are very simple solution for this group of people who are suffering from reduced ejection fraction or non-reduced ejection fraction. Non-reduced ejection fraction, we call it HEPEP sometimes HEPEP plus MREP. So there are some trials, like when you do not know the ejection fraction, like Consensus, VALEP, Impulse, and EMPEREC, there are some trials where the ejection fraction less than 25%. So let's talk about the HEPEP, where the ejection fraction is more than 40%. And you have many drugs and many devices also. And the old kid in the town will be your ARNI and SGLT2. And there are just recently published trial like Paraglide trial on ARNI. It has told us that if you introduce ARNI very early in the journey of heart failure, you can reduce the pro-BNP. We also know that the copper chelation also can reduce pro-BNP, the echo dimension, etc. We have new drugs, Williviavelo like Kerendia, that is Fineron, for the treatment of heart failure. So these are the future trials which will be dedicated for heart failure with preserved ejection fractions. So far we know that there are many drugs which may work, may not work in the patients who are suffering from heart failure with preserved ejection fractions. What are those? A top cut. Initially it was a failure, but when the study was done in US, if you leave aside Brazil and Georgia, most of the patients which were recruited from the US, it has shown that the spironolactone does improve the quality of life, does reduce the heart failure outcome. And the FDA has approved the aldactone with the new guide, with the new recommendations after winning 13:1:1. So one person abstained from the vote, but 13 people out of 14, they voted for aldactone in the TOPCAT trial. So there are previous trials, so there are newer trials like Paragon HF. We know that on the basis of ejection fraction, you can prescribe ARNI up to 57% to 60% male and female, and we know now that the ejection fraction between male and female are little different by 3 to 5% all over the world. And DELIVER trial has also contributed to large extent that knowing the left atrial dimension also improves the outcome. If you can reduce the left atrial dimension, volume, and other biometrics of the left atrium, including the ventricular hypertrophy, ejection fractions, left ventricular diastolic volume, systolic volume, you can improve the quality of life, reduction of pro-BNP, and also the newer thing is coming like GLS. Like for amyloid, you can have almost a normal ejection fraction of 60%, but the patient's GLS will be 7, 8, or 10 because they are very sick patients. So we are moving away from ejection fraction to GLS, and whatever may be the ejection fraction, somebody who is suffering from fluid congestion, overall fluid overload, and is symptomatic in the form of dyspnea or edema, raised JVP, enlarged liver, all they need is diuretic first, followed by ARNI, then SGLT2. If it is diabetic, definitely Fineron, beta blocker if it's hypertensive, ischemic heart disease. So knowing the microvasculature, knowing the coronary artery, knowing the phenotypes are very important. It is a continuous spectrum, and this spectrum is getting better and better, getting closer and closer by knowing the fact that you maybe have a different spectrum, but ultimately 2-3 drugs are very useful irrespective of the ejection fraction. What are those? There is ARNI, there is SGLT2 in diabetics, and SGLT2 definitely with heart failure reduced ejection fraction, you get the value for money in patients who has got lower ejection fraction. The benefit of any new molecule, costive molecule like SGLT2, whether it's DAPA, EMPA, CANA, or sotagliflozin has recently been approved, comes down if your ejection fraction on the lower side. But I feel the field of ARNI or RAS inhibitions is going beyond heart failure nowadays. There are recent trials, a recent study in Japan that all these hypertensive people who has got some evidence of end organ damage like left ventricular hypertrophy or LA enlargement, they need ARNI very early in their life because it can reduce the progression of heart failure with incipient heart failure or a risk factor for the heart failure in the future. So better to start your journey of hypertension with RNA-like molecules. This is again conjectural. It has to be supported by a lot of trial. So Paraglide trial is out, and MREP and HEPP patients does benefit from your combinations rather than pure air with this valsartan. Now, this is the strong remaining unmet needs in Asian population, especially hypertensive patients, those who are having very bad family history of landing into heart failure, stroke, or atrial fibrillation. So, a lot of comorbidities. You have to provide us the ventricular dimensions, left ventricular hypertrophy, and LA dimensions. Now, you know, this mitochondria is the game changer, and we can target the mitochondria by new drug like SGLT2. This is a cancer cell. A lot of mitochondria. 3 nucleus. We can go for mitochondrial transplant, but we have a pharmacological alternative to mitochondrial transplant, that is SGLT2. So there are a lot of comorbidities. There are pathophysiology like hyperinsulinemia, insulin resistant, obesity. Now there are 2 different a type of mortality in male and female, like a smaller coronary arteries, the risk of ventricular tachycardia, INOCAS, and they respond better than the men. The women, they respond to any therapy like ICD, CRT, His bundle pacing, and they do respond to this drug but better than the male. The male has got more ischemic heart disease, they die early. So there are trials in heart failure with diabetes, diabetes in heart failure. So these are now interchangeable. For example, Paradigm trial has 35% patients had a prevalence of diabetes. If you have pre-diabetes or established diabetes or the microalbuminuria with microvascular disease, obviously there will be more mortality. So getting with the GDMT, like if you bring them to your GDMT full-fledged therapy, definitely it improves the outcome, and echocardiography and other parameters like the biomarkers can help in the initial diagnosis. So echocardiography, chest X-ray is a must along with the clinical examinations. So other factors like I mentioned, cardiovascular death, total hospitalizations, everything changes with early therapy, and diabetes is intimately related to the outcome of heart failure therapy. So there are trials like CHAMP, PRESERVE. You have imputed analysis when the CHAMP PRESERVE trial was compared with your imputed analysis, ARNI was the winner. So you have a normal glycemic, pre-diabetic, diabetic, and previous diabetes mellitus with macro-microvascular combinations. So these are basically clinical phenotypes. So in these phenotypes, this is quite prudent to start your therapy, like heart failure, preserved ejection fraction, diabetic, renal dysfunction. What do you choose? You choose ACE inhibitor, ARB, or ARNI, because ARNI causes less hyperkalemia. The Finerenone causes less hyperkalemia. So microalbuminic heart failure with renal dysfunction, diabetic patient is worth starting Finerenone, ARNI, SGLT2 plus minus diuretic. Beta blocker role is doubtful here. So we have a combination of many other things like obesity, metabolic syndrome. So it's a continuous spectrum. And do we have drugs now? And we have different kind of drugs which can tackle the obesity. So lifestyle modifications along with the new drugs are very much essential to treat the complication of diabetes, the heart failure, preserved ejection fractions, pre-diabetic, diabetic with macrovascular complications. Earlier you start, greater is the benefit. And usually most of the patients who are suffering from hypertensive or normotensive heart failure, they do tolerate 200 milligram of ARNI, 10 milligram of dapagliflozin, 20 milligram of Finerenone. And we know that it works at different levels, starting from the glomerular, afferent, efferent arteriole in a combinations to your mitochondria, the superfull hypothesis. There are a lot of evidences that SGLT2 is the medicine of choice or the drug of choice, irrespective of the ejection fractions in many patients with or without diabetes, and it also can prevent a lot of arrhythmias, does reduce cardiovascular death. So there is no doubt in my mind that all heart failure patients should be treated according to the guideline, but you cannot avoid SGLT2, ARNI, Finerenone, other drugs in heart failure with preserved ejection fractions. If they are volume overloaded, you can monitor them by remote monitoring, redox system. But at the end of the day, you have to know the coronary artery disease. You do the angiogram if somebody is suffering from tubular vessel disease. You can go for CABG. If somebody is suffering from MR, you can go for mitral clip. If somebody is developing rapid atrial fibrillations, oral anticoagulant plus control of rate. So ARNI and Kerendia has reduced, and especially the SGLT has reduced the incidence of hyperkalemia in the world. When the RAILS trial was released, in Times Magazine has reported that the incidence of hyperkalemia in the world has increased, but gradually because of these newer drugs, which are less hyperkalemic, are basically changing the game of hyperkalemia. So GLP-1, again, you have the new molecule that oral semaglutide, Rybelsus, which reduces the weight, obesity, and Adnan Swami would have been much happier if he had the access of Rybelsus 10 years ago. We can reduce up to 30 kg of body weight if you introduce the GLP early in the life. So in conclusions, we have many drugs. These are 4 fabulous drugs there for heart failure, reduced ejection fractions, but at least 2 drugs along with diuretics and the newer drugs like Fineron can do a wonder in patients suffering from heart failure with preserved ejection fraction. Echocardiography with ejection fraction, GLS and other parameters can help a cardiologist to choose the molecule very early in the life. This is not a one-day thinking, it's a day one thinking that all heart failure with preserved ejection fraction, they have equal mortality as bad as heart failure with reduced ejection fraction. They need special care. Thank you very much.